Okay, so this is going to the hospital in Canada. Not quite. It's a good friend of mine. He's an Immersion doc. So I'm just going to talk really quickly about, just to lay a bit of groundwork about the difference between Canada and New Zealand, or explain at least Canada, just to let you know that for most people to get into medical school, they have to do probably a 4-year undergraduate in something. And now it can be just about anything. So it can be theology, it can be sciences, it can be whatever. Some people will then go on to get a master's or a PhD and then get into medicine, but usually, almost everywhere, it's 4 years first. Then the medical degree is almost always 4 years, except for 2 schools, which are 3 years. And then residency is 2 years in Canada. I think we have the shortest of all the family practice GP residencies. You can get additional skills for another 6 to 12 months, and that can be emerge, palliative care, whatever you like. But you can do all of that anyway as a family doctor. So that's kind of the background of what we do. The big thing right now in Canada is something called the CCC curriculum, and that is comprehensive, continuity, and centered in primary care. So that means you get exposed to everything a GP should or could do. So it can be, you'll have to be exposed to, even if your main teacher doesn't do deliveries, like I follow women to 20 weeks and then hand over, but they will get exposure to where I hand over. They get continuity of care, so they get a panel of patients that they see all the time, and they're actually assigned. I'll get a group that are assigned to me for the full 2 years. So they're coming back for half-day backs every week to continue to see, and we try and book those patients with them. And then about 50% of their time is in primary care. So for the first year, it's 5 months of residency just in family medicine, and then they come back every week on all the weeks where they're off service. So they come back for half a day. So it amounts to about 6 months. The second time, it's not at your primary academic center. You do 3 months of rural and 2 months of urban, and then you still do your half-day backs whenever you're around back to your center. And we try and give them selectives and lots of opportunities. So if you wanted to do more of something, you can kind of explore that during your family medicine block time. We really strive for learning over service. This has been a huge shift in Canada to focus on the learning for students, and that's right at the grassroots level. So let's say in my clinic and I want them to see certain patients, I will actually do their notes for them so they can hurry through and get to see people and get exposure to some of the patients. And on the broader sense, if we hear there's a lot of complaints about residents just being used for service, we actually have closed rotations before, and that used to happen much more commonly than it does now. But when I was first at the U of A, we were closing rotations probably once every 2 to 3 years because they were not really providing a lot of education. It was mostly service. We have half-day backs, we have an academic half-day where they come into the university setting and they attend small group sessions in large groups, and we do workshops and all sorts of stuff with them. I just wanted to tell you what the average day of clinic looks like for in my clinic, and everyone varies a little bit, but on Wednesdays is one of my clinical days. I show up just before 7:30 and we meet with residents, and they do presentation rounds. So they will take a case from what they've seen and talk about what they'll let's say present. 38-year-old man presents with abdominal pain. And then the rest of the residents will start to ask questions. When did it start? How long has it been going on for? What makes it better? What makes it worse? What does the pain feel like? All that kind of thing. And then they'll build a case. And the goal is for them to get one of 99 core topics. And every day we do 2 cases. Every Wednesday we do at least 2 cases. And by the end of their rotation, they've built up we've gone through most of the 99 core topics. Once that's done, it's about an hour long. Then we enter the clinic. It's about 8:30 now, and they will see patients until 11:30. In an ideal world, they'll see between 4 and 6 people per half day. The reality is early on, they'll see a little less, and later on, they'll see a little more. What's the average in the US for third-year residents to see a family practice? How many do they see in the US? 3 people per half day. It's actually tiny. So it's interesting. That is changing, but that used to be the way. They see patients alone for the most part, and then they come back and see me. We discuss it, and we go in together. And as they graduate to later in their second year particularly, they're seeing and discharging people on their own. And about once a month or once every 2 months, they have to follow up because they missed something, because we review all the cases afterwards. What's been shown is as you separate yourself from learners, they become more independent learners. If you're right in the same room as them, the research shows that they'll continue to rely on you all the time as their safety net. So we try and actually distance ourselves a little bit as they get more. And we try and get them to move from a reporter to a clinician and then even a teacher where they could be, have students themselves. The last thing is one of the things we do very well, or we've been said very, very good things about, is we do something called this observation and evaluation. We call it competency-based achievement assessment. So when you're actually in there, one of the things residents and learners complain about almost universally in the world is they never get feedback. And one of the problems is they don't know when they're getting feedback. Like, stop that right now. They don't know that that was good feedback. So but they don't really know that that was feedback. And so we have a discussion ahead of time with my residents, but also we write little notes so that when they're seeing someone, I might go in the room with them and say, I want you to explain that we're going to send her for an x-ray and start this right now, or have a plan to call her up once we get the x-ray results. While he's talking or she's talking to the patient, I will be writing a note about the style of communication and that kind of thing. So that's one of the things that we've done well, and it's being adopted around North America. Now, how do you give feedback? You use the sandwich technique, right? So I thought I'd go through what sandwich technique looks like in Canada. That's a nice tie. So that's the upper part, right? That's the, you're doing good, I like you, that's the positive thing. I knew he liked me. That's what the resident's thinking. So then we progress to what you really want to tell them. Your care of that patient borders on criminal. Okay. Now what the resident's thinking? I haven't seen anybody today. Okay. Then remember, you have to end positively. That's a great tie. He does really like me. Okay, great, thanks.
Wow, there were some great ideas there. I think we're going to have lots of great questions. So now I'm going to hand over to the second Mike, Mike Loten.
It's unfortunate that I'm following on from Mike Allan because not a shred of my talk has got any evidence base at all. So I'm talking today from my perspective, which is as a rural GP. And I think really the take-home message for me to you guys is that for students and registrars to learn, I think they need to feel valued. And I think they also need to know that they are adding value to the practice, and that makes a huge difference. So from my perspective, as a GP, as a teacher, and as a former student, I think that the optimal teaching takes place when people feel valued and when they feel like they can add value to the environment they're in. So we need to foster an environment that welcomes people, that allows them to ask questions, that allows them protected teaching time and recognises their individual worth. So how do we stop this situation happening? So the most important element in the learning environment is invisible. It is made up of the values, the attitudes, and the actions that our team models every day. And that's taken from a UNICEF teachers discussion forum, I think based in primary schools, but I think relevant to us as well. So how do we do the nuts and bolts in terms of making it a quality experience? We start with the preparation. So even before the student or registrars arrived, we establish contact with them and make them feel like that, they're going to be welcome. We ensure that they're set up properly with a name badge, that they're, all the IT stuff is already set up before they arrive. And we help with accommodation, particularly with the students. We try to immerse them and get them living in the community with our staff members. For orientation, we try to get them involved in the three core sort of areas of our practice straight away, and that's, the admin team, the nursing team, and the medical team right from day one. That's to emphasise the collaborative nature of primary care. And we get them exposed early to the key community players. From my point of view, that's the district nurses, the pharmacists, ambulance officers, and the physios. And then later we expose them to the other kind of community players. We always sit them in the waiting room for a session early on to get a patient's perspective. And I always have a session with them quite early on to talk about general practice as a business, because they need to understand that they're contributing to make the business run efficiently when they're working with us. In regards to the team, I think that that sense of value they get when they get their hands dirty. So we get them in to see the nurses, particularly the students, to do as they're able to in terms of their experience. Simple dressings, liquid nitrogen, suturing and stapling and so on. And we get them going out on the prime calls and the emergency calls whenever possible. And the peer review and clinical meetings, we always try to make sure that they're invited and come along to them, and any social outings, obviously. Patient contact, again, very early, as Mike was saying. I think that's really important. And we always get our students and registrars to sit in with all three of the fellows in the practice, so that they get a flavour for how differently we all practice. And we allow our students to see patients as early as possible to start getting a feel for taking history and getting an idea about a management plan. Right through the attachment, I always try to keep sitting in with registrars right through to the end, because I think that's an incredibly valuable way of giving feedback to the registrars, and we use role plays as well. And obviously allowing time each day for the registrar to come back to us about what consultations they found challenging. And as Mike was talking about with appraisal and feedback, we have the formalised stuff, which is from the college or the university, but we also have our own little feedback format, which is both informal and formal. This has got nothing to do with quality general practice, by the way. But I just want you to bear in mind that when wives ask their husbands to come to the doctor, this is exactly what goes through their minds for prostate checks. Thank you.
Thanks, Mike. I've had the pleasure of doing many registrar visits at Raglan, and they're always happy people, and it's very clear why. So next on to the platform, please, is Bronwyn.
Kia ora koutou. Thank you, Sam, for roping me into this. Mike really underplayed the registrar involvement in their social outings. The Christmas parties at West Coast Health Centre are legendary, I've been told. Medical educators have long understood that good doctoring, like ducks, elephants, and obscenity, is easy to recognise but difficult to quantify. The statement was made in an article in the New York Times a couple of years back. Good GP teaching has much in common with good doctoring. It's hard to measure, but as is the case with ducks, elephants, and obscenity, there are some distinguishing features of a quality experience that we can describe. I'm fortunate to have spent time every week for the past 5 years with successive groups of highly intelligent and articulate young doctors who've given me lots of feedback. They've described the quality experiences they've had with the awe-inspiring GP teachers in our region. So I've collected some of their feedback to share with you. Reflecting on what they value, some themes have emerged, and these can be grouped under 3 headings. They're principles with which most of us are familiar, and which are sometimes referred to as the 3 Ps. Participation. Having a mix of patients with chronic conditions as well as acutes. Spending time with the practice nurses. Regular one-on-one teaching. Doing role plays with the teacher. Being observed by the teacher and observing their consulting style and the style of the other doctors in the practice. Having a variety of different types of teaching. Doing community visits and spending time with the GP2 registrar in the practice. The second P is for protection. Having a well-planned orientation to the practice. Having teaching time that is always protected. Receptionist and a practice manager being familiar with the requirements of the GP1 registrars regarding appointment times, teaching sessions, surveys, video consents, and knowing how to support me. One of this year's registrars has said, "I felt very much at home at this practice, and I think that came from feeling very well supported. I'm grateful for this, as it's improved my confidence in general, as well as making work an enjoyable experience." The third P is for partnership. I felt very much accepted as part of the team. It was valuable to be present when other GPs were discussing their difficult cases. This is a wonderful practice to work in. Communications flow easily among doctors and nurses, and everyone works in a harmonious environment. We have regular meetings that cover a variety of topics each week. And finally, there is a great team ethos and passion for what they do. The environment seems to be important, but what is it that creates this environment? When used in the context of the Treaty of Waitangi, the 3 Ps refer to aspects of the relationship between the treaty partners. In this context, they describe aspects of the relationship between the registrar, their GP teacher, and other members of the practice team. I love a good TED talk, and one of my favourites is by Rita Pearson on educational reform. She says that no significant learning can occur without a significant relationship, and she talks about the value and importance of human connection. Our communication curriculum relies heavily on the Calgary-Cambridge Guide to the Medical Interview. We recognise that establishing a therapeutic relationship is one of the principal goals of medical practice. Perhaps a quality experience in general practice happens when the teacher is registrar-centred, in much the same way that we teach them to be patient-centred. The theme of the conference and of this panel is innovation. Innovation means introducing something new or different. We're living in a time of change in general practice, and much of that is really exciting. We're experimenting with new models of care, new tools, and we're integrating with secondary care, and I embrace all of this. The question that I have is whether this is the right time for more innovation in GP education. It seems to me that from the time I started as a medical educator, there have been successive innovations. In 2010, we had the mid-year intake experiment. We've had training in another vocational scope introduced and withdrawn. We've had a training delivery review. This year, the interview process was changed. I still don't know why. And the placement of registrars and teaching practices will be done differently this year. Through all of this, GP teachers and medical educators around the country have continued to deliver really good quality GP experience to our trainees. Perhaps another innovation is not what we need right now. Perhaps we need to concentrate on valuing what we know is good, supporting all of our teachers and teaching practices, not just to meet the standards that have been set, but to emulate what has already been done by those who are working at the top of their game. A great example of this was demonstrated in a really moving way by the recipient of the Eric Elder Award yesterday. Congratulations, John.
Thank you, Bronwyn. Lots of food for thought. I'd now like to ask Susan Hawken to take the stage.
Hi, thanks Liza, and thanks Sam for inviting me. I feel very privileged to be here, and a number of key themes that I had in my presentation have been sort of brought through right through the conference, and I hope that I can reflect on some of these for you. So I'd like to take you on a journey. I'd like you to imagine a world in which students were selected into medical school, were representative of our communities, and were educated in an ideal way. So they weren't bullied, they were valued, they were taught about how to interpret evidence, and they were inculcated into the patient-centred approach from day one. And as has been said, that the Calgary-Cambridge Guide is being used and will continue to be used as a base to teaching of the consultation. So hopefully we have a very well-prepared student for general practice, who then go and travel to a practice which maybe is in a community that is unlike their own, in which they are welcomed with open arms into a rich, diverse experience of patient-centred care. in which patients, nurses, pharmacists, community workers and other frontline staff all feel empowered to share their knowledge, skills and experience with the students, in which students feel valued and understood, in which their learning needs are met as the way that we meet the needs of our patients. And in particular, the patients feel it is part of their work to educate students on their illness, on their lived experience, and that within that special place, within the consultation room, where patients reveal their most precious stories to us, that the students can feel comfortable and part of this process. And in turn, that back home in the ivory tower of the university where I live part-time, that the academic GPs and the administrators can understand the pressures that you are under and also the preciousness of this experience, and that we can support both practices and learners in this. Imagine such an inspirational place. This is like Carfield, or Raglan, or Rawene, or Matamata, or a number of other places from which we know our students go and have the most astounding experiences. And I wish to thank John and Karen and Sue and the team from Carfield yesterday for the most moving speech, which really said everything that I wanted to encapsulate, but a lot more eloquently. As this conference has emphasised, it is about the relationship and the patient-centred interactions we have and the relationship that we have with our learners that makes a learner feel safe and able to ask questions, to challenge, to grow and develop. This is what I dream of for our students. Reflecting back on my experience, it was a rural general practice experience in Papamoa, which is probably not that rural now, and a little bit of Makatū that made me become a general practitioner. So moving on to innovation, the university would like to believe it is very innovative, and in fact we have done some innovative things. I think our Pukawakawa program in Northland has been innovative. Our students in their 5th year go to Hokianga, to Kaitaia, to Dargaville and to Kaukaua. They're out there in the community experiencing those things, and they live together in that whangarei base. So there's lots of things that have been said that program features. The RIP program, the Rural Health Interprofessional Immersion program, that's funded by our Health Workforce New Zealand, is another good example of a community experience that puts rural needs, Māori needs, and patient safety at the fore. More recently, the new Year 4 attachment, which I'm currently overseeing, is an experience where students will be going for 2 weeks into primary care. So the general practice may be the base, but the idea is that the students are out there with all the allied health workers, with police at the front line, and hopefully getting to practice some procedures that they've just learnt on their emergency medicine attachment. There are other innovations, and we are moving more into the regional areas of New Zealand. But I'm not here just to talk about the innovations from the university perspective. That is only one very small part of the wider story. I think innovations come from patients like June, who touch us and touch our learners. From a little patient that I had the other day, and I shared this story with the workshop yesterday. Little 4-year-old boy was in a side room seeing one of my students. He then came into the room with me and he said, "Dr. Sue, I don't want to be your patient anymore. I want Dr. Nick for my doctor. He's wonderful." Innovation also comes from general practitioners, from receptionists, the frontline staff that are so important to make our practices work, from our other practice nurses, from our other helpers, and from other people in the community. That's where I believe the innovation comes from. I was going to read a number of words from students, but throughout this conference we've heard lovely feedback, I think, from students, but there's just a couple I wanted to share. This is a student that recently went to Tamaranui for their GP placement, and they wrote and said that I found out this is much more about the patient than the job. It was a real eye-opener. The way the staff and the patient reacted to me and to what they were doing, it was so rewarding and it was very influential. And I'd just like to finish there and to thank all the practices for taking our students. We really appreciate it.
Thank you, Sue. It's very exciting stuff going on at Auckland University Department of General Practice. I am biased because I do work there as well. So now, last but not least, is Dominique, who is going to give us the most important perspective on this issue.
Thank you, Liza. Good afternoon. I thought I'd just share a bit of my background first. So I'm in GP2 currently, and also 5 years down the track after finishing medical school. My general practice experience post-grad includes the 3-month rural GP run as a second-year house surgeon, and I'm now 18 months into the Registrar training program. My first couple of house surgeon years were spent rotating through Waikato Hospital, and then I did a year of ED in Blenheim before coming into general practice, and I'm now based out in Matamata. So I thought the most useful thing to share this afternoon was my own experience as a medical student and trainee through my GP rotations. I don't think it's changed much, but out of the 6 years we had at medical school, we get 10 weeks of general practice experience, 4 in our 4th year and 6 in our final year. So that's just 10 weeks of exposure to try win over the medical students that general practice so desperately needs. After my experience in 4th year, I had no intention of ever going into general practice. I left not even feeling neutral towards it. I had quite a bitter taste in my mouth after leaving that placement. The reason I'm standing here today, and the reason I'm working full-time in rural general practice and loving it, is almost solely because of my GP placement as a trainee intern. So why and how were they so different? It is true that a lot of how placement goes depends on the trainee's attitude, and I can't say enough about that. If you're not interested or you're lazy, you're just not going to get much out of it. But the somewhat unfortunate truth is that if you have a negative experience with a teacher, almost certainly you'll be turned off that specialty. And this is exactly what happened to me in 4th year. When I spent 2 weeks at a semi-rural general practice, I left feeling undervalued, and I think value has been a real theme this morning, a little bit useless and patronised. As a result, I didn't want a bar of general practice, and my TI year rolled around, and I was just interested in getting my GP run out the way. I split my 6 weeks and ended up placed in Kawhia for the latter half of the run. And contrary to 4th year, my teacher made me feel as if I was contributing to the practice. I was encouraged, I was included, and in such a positive environment, I thrived. I left having enjoyed that placement more than any other through medical school, and as a result chose to consider the second-year house surgeon placement. And again, I was placed in a practice with a dedicated teacher who enjoyed his job and encouraged me, and that was enough to make up my mind. I don't know too much about what's happening with the near future GP registrars. There are more of us coming through, thank goodness. But more of us means an increased demand for teachers and an increased demand on our teachers. And the GPEP 1 year is extremely important in setting us up for pretty much solo practice the year afterwards. I was fortunate enough last year to have been placed with one of the best teachers I've ever had contact with, and came to understand how fruitful a mentor relationship can be when it works well. If I reflect on my time last year, it reminds me of how physicians trained a couple of thousand years ago, taking an apprentice under their wing and teaching them about their art. If we spread our teachers too thin, or load a practice with several registrars under several teachers, we will never capture the physician-apprentice relationship model that works so well to produce people like me at the beginning of their general practice careers, who want to be just like the quality teachers that they've had in their past, enjoying their working days 25 years down the track and passing on their knowledge in a meaningful, connected way. Some doctors just don't want to teach and don't enjoy it, But I think most of us probably have a slight interest in it, and we have the obligation to pass it on. And I hope that someone reminds me of that in a few years' time, Bronwyn, when I think I'm too busy to take on a student. So those are just some thoughts and reflections on my experience. Thank you.
Thank you very much. I think that one of the resounding things about this conference has been the voice of the students that's come through in so many of the presentations, and they've been so eloquent and so powerful and are so important to the lifeblood of our organisation. So thank you. All right, now the floor is yours. The mics are out. So do we have any questions, please? I can't see very well from up here, so you're going to need to wave very muchly. Any questions, any statements about the teaching? Sam?
I was just going to ask Dominique, I know Mike talked about feedback and it needs to be in a positive way. So what would you feedback to your fourth year teacher in a positive way?
I won't tell you the name or where I was. I guess reflecting on it, and especially, preparing this little talk and realising just how negative that experience was for me. And if I didn't have, I guess, the saving experience in my TI year, then I wouldn't be in general practice today. I really wish that I had said something, or I'd reflected on it with that teacher, and potentially I didn't do that because I was just a bit nervous and only in fourth year, or potentially there wasn't a space, an appropriate space, either at the end of the attachment or with the organiser of the fourth year attachment to be able to do that meaningfully. Yeah.
Any other questions? Oh, Helen.
Just to pass the time a little bit. I was just muttering to Ralph about the feedback for teachers, and I think this highlights a little bit too the different approaches between the universities and the college, and how do we work together to actually lift the teaching standard and the enjoyment across the sector? How do we make sure that everybody's valued? Because I think you do hear anecdotes all the time that there are areas of concern, but it's not just in one part of the program. And I know there's a shortage of teachers, but a poor quality experience has just been demonstrated to be not worth the time that it was given. So we have to be really, really careful about that and not just go for volume. So thank you, Dominique, for raising that.
Anyone on the panel wish to?
Say something to
Yes,
that?
please.
Yeah. I think one of the things that Auckland's done more recently is that both our head of department, Felicity Goodyear-Smith, and Tanner Fishman have visited a lot of practices in the last year. They've made a really big effort to look at the quality of practices and to look at capacity issues and to visit and support practices, particularly around this new year 4 attachment. And as a department, we intend in the future to each have a group of practices that will be on our list to visit on a very regular basis. And we're going to have a new database so that we can be supported in this. So I hope that by visiting and actually establishing a relationship, like it's been amazing this last few days to actually meet people that are taking our students. And I think it's in that relationship that's going to make it easier for me to ring a practice or the practice to ring me for the group of practices I'm looking after. So I hope through that process there'll be a relationship. And then some of our online modules that we're hopefully going to develop are going to help to upskill people. So it's just a few thoughts.
Mike, can you shed any light on the Canadian experience, please?
Yeah, so we have a very similar issue with if the learning experience is poor, that basically turns them off. It's very hard to get people back. And we've actually been quite aggressive at trying to weed out people who, when the learners are showing up and the first thing they hear is, don't ever do general practice. That's actually been found. It's terrible. And we're trying to encourage those who we know are good teachers, but sometimes are nervous about their ability to be a teacher. And, we're all learning all the time. I don't think people really need to take a step back and realize that no, you don't have all the answers. And that lends to one thing that I did want to comment on, because I joke about feedback and that kind of thing, but I actually think exactly what was said by Mike, that you need to feel valued as a learner. And one of the things I spend time at right at the very first day is talking to them about the power differential that exists. That unfortunately, in the end of the day, we're going to have to decide. Sometimes I'm going to have to overrule what you want to do because these are my patients and I have to be comfortable with that. But I remind them that a lot of the time we have different approaches. It doesn't mean they're wrong. Because if they went and worked with another one of my colleagues, they would do something else in that very same setting. And I remind them too that when we're quizzing them, and I ask them if I can quiz them first, and then when they all say okay, because I want to be pleasing, but I remind them that I can always embarrass them. But they could do the exact same to me. So when we get to a point where you don't know, don't ever feel embarrassed about that. The point of being here is to learn. If you knew everything, you wouldn't need to be here. So I spend a lot of time trying to reassure them and that kind of thing from a personal perspective. And then from a larger perspective, our program, we're very conscious of the experience that the learners are having because they need to learn, but they also need to feel welcome so that they'll come and consider general practice as part of their career.
Thank you. We've got Lydia here and then gentleman over there.
My question is much the same. How can we make it easier for students to give feedback as they go through?
I had a teacher one time, he was great. He was one of the best teachers that I've ever had. And he used to say to me, I'm only going to give you feedback if you give me feedback. And it can't all be good. And that was really hard. You can imagine that power differential, having to try and find something that, fortunately, he believed that you only needed 3 hours sleep a day. What do you think happened to him when they turned out the lights for rounds? He slept through every single round we ever went to. So I told him about that. That was my way out. But I think you have to kind of force them to, and some learners are much more comfortable with that than others. And it's a very hard thing because of that power differential. And you have to be, I think, over time, because we get, how long do you get to work with a student or a registrar? How long?
The registrars have 6 months attachment.
6 months, you can usually break down most barriers during that time. But I think that we have to do that to make them feel comfortable.
The registrar's feedback is a requirement of their attachment.
Yeah, but is it a written or is it verbal?
Written.
Yeah, so we get written. I like it better when they tell me that, because when they'll talk to me about something. And I had one of my best residents used to tell me, I don't know how long, he was with me for 2 years, we never agreed on how to suture, never once. And you know what, we were both wrong, and we were both right. His looked just as good as mine at the end of 2 years. So it was a very interesting learning experience for me, and I think you have to be okay with them saying, I'm not, like, this is how I want to do it, or something like that. He was good.
Oh, sorry, Mike.
Yeah, no.
But just one last question before we wrap up.
Hi, my name is Adam. This is not in line with the current discussion right now, but generally I thought it's very important. I'm educated in Singapore, and I've taught medical students since 2008 actually, in our major medical school. And recently from Lee Kong Chin's tied up with Imperial College London. Now, there's one thing I noticed about teachers is that they get burnout over time. And apparently, throughout the years, this thing has been addressed by actually remunerating them, giving them an honorarium per an hour when they are teaching. We have to understand that we're setting a GP practice here, and it's business as well. And apparently, the teachers are motivated. They feel they feel the sense of Australian idealisms to actually teach. But they've been struggling with this business aspect as well when trying to spend time with the students and at the same time caring for their business as well. So I'm just wondering whether the New Zealand practice actually addressed that, like motivating the teachers that, hey, if you're going to teach students, we're going to give just a small token of appreciation for what you are doing.
I think I can probably answer that because I know that at the university and also if you work for the college there is remuneration. But you know, I do wonder, and this is where I'm going to wrap this up, whether we've heard a lot about prods and things. Perhaps a prod in the opposite direction to say that people who teach, that should be a quality improvement activity recognised at a national level might be an interesting way to go forward. Thank you so much, everybody, for your comments. They've been fantastic.